Hello, everyone, and welcome to week 4, Thought Disorders. We're going to be spending some time together talking about thought disorders, and that's going to include also dementia and delirium. So, assignments for this week are Chapter 11, and Touset and Fitzpatrick, and Chapter 14, and Boland, and Chapter 5 and 3, and also your DSM 5, looking at schizophrenia and psychosis and neurocognitive disorders. You will have a journal entry due this week, and there's quiz number 2, a discussion board, and like I said, a journal entry. So, two types of thought disorders. You have thought disorders related to schizophrenia, schizoaffective disorder, bipolar type, or depressed type, schizophreniform disorder, and then schizotypal personality disorder. And then your neurocognitive disorders are delirium, dementia, such as Alzheimer's, vascular dementia, Pick's disease, Lewy body's disease, and then other neurocognitive disorders such as Huntington's disease and a traumatic brain injury, etc. So, what it is and what it isn't. So, psychosis is not a disorder, it is a symptom. So, psychotic expression does not equal a psychotic disorder. Previously called dementia praecox by Emily Kraepelin in 1876, meaning a deteriorated, hopeless condition with poor prognosis. It's not split personalities or multiple personalities, and we want to consider the role of culture and cultural interpretation with these disorders. Incidence and prevalence. Approximately 0.7 to 1% of the adult population have schizophrenia. Rates may be as high as 10% in those with first degree relatives with schizophrenia, and up to 40 to 50% with an identical twin with the same disorder. 24 million people affected worldwide, 4 times as many men as women. Approximately 0.3% of the adult population have schizoaffective disorder, generally considered to be a serious and persistent mental illness. So the prognosis of a serious mental illness, suicide is a leading cause of premature death for patients with a serious mental illness. Clients also have a lifespan that is 10 to 20 years shorter with a serious mental illness, and up to 80% of clients with a serious mental illness use nicotine regularly. Remember, we in your first course we talked about nicotinic receptors and what they can do. Um, Agnosia. You guys did a lecture on that the first week. It's to not know or realize that he or she is suffering from an illness. So that's anosognosia. So schizophrenia versus schizoaffective disorder. Disorder, excuse me. Schizophrenia has positive and negative symptoms. It's consistent, though may have exacerbations. Schizoaffective disorder is positive and negative symptoms and mood fluctuations consistent with either depression or bipolar disorder. Therefore, you can either have schizoaffective, um, depressed type, or schizoaffective bipolar type. The etiology, there's the dopamine hypothesis, the hyperactivity in the limbic system, hypoactivity in the frontal region. Explanation is likely too simplistic to fully describe the phenomenon, but it it does bear some um, evidence for the role of dopamine. There's the role of serotonin, inhibits dopamine synthesis. Second generation antipsychotics, they block dopamine and serotonin levels. And there's the biologic and genetic factors. High prevalence in families suggest a genetic predisposition. Increase in incidence when mom is exposed to flu in second trimester. perinatal asphyxia, substance abuse in pregnancy, and maternal malnutrition. Talk a little bit about positive and negative symptoms. We've discussed this in previous classes, but again, important to know and memorize and just always have with you. Positive symptoms happens to a person. So hallucinations, delusions, including paranoia, illusions. Negative, that's taking away from a person. So depression, social withdrawal, social intolerance, apathy, disorganization, flat affect. How do we assess psychosis? Well, I think the best way is to listen. And sometimes it's not always evident when you first talk to someone, and especially if you just talk to them superficially. Like, hey, how you doing? How's your day? You really want to get deep if you start to notice things are just seeming a little off. You're going to have to start to go deeper. You want to validate the feelings of the client. Be calm, consistent voice and body language. Be non threatening. Be mindful of excessive information at one time. Don't discount their capabilities or knowledge. Be mindful of social intolerance and be creative when working with these clients. Hmm. A mental status exam for someone. Their appearance may be disheveled, poor hygiene, incongruent, bizarre behavior may vary in their ability to cooperate. Mood can be labile, depressed, euphoric, irritable, angry. Their affect could be flat or blunted, expansive, labile, incongruent. Speech can be hypoverbal. They can have clang associations, echolalia, where they repeat what you're saying. Thought processes could be tangential, circumstantial, impoverished, flight of ideas, loose associations. Their thought content, they could be homicidal, suicidal, delusions, hallucinations, perceptions, hallucinations of all five senses, cognition. They could be alert and oriented, but they may not be alert and oriented. Insight typically is poor, judgment's typically poor. So, differentiating psychotic disorders, you're going to want to refer to your DSM 5 for that too. There's schizophrenia, schizoaffective, delusional disorder, schizophreniform disorder, and schizotypal personality disorder. You want to rule out, excuse me, bipolar mania with psychosis, depression with psychotic symptoms, substance induced psychosis or acute intoxication, which I am seeing a lot of that more often from methamphetamine abuse. I do work inpatient psych sometimes, once a month or so, and see a lot of substance induced psychosis or cannabis induced psychosis as well. Psychosis induced by a physiological condition, major depression disorder or bipolar depression, anxiety disorders, autism spectrum disorders. So you're going to rule those out. So here's a basic treatment algorithm. You have your step one, a single second generation antipsychotic. Step two, maybe a different one. You tried one that didn't work. You may have to move to a second one. And then step three is either another one or a first generation antipsychotic or clozapine. You do need a special course, a REMS course, to be able to prescribe clozapine. So you have to take that. And then step four is clozapine plus a first generation antipsychotic, second generation antipsychotic, ECT. And then step five is multiple antipsychotic therapies. We always try to avoid multiple antipsychotics in patients. However, sometimes there is no getting around that. Uh, you may need to do that, but I would always consult with someone and you want to document why a patient is on multiple antipsychotics at every visit. Pharmaco, interventions, second generations antipsychotics, again, your atypicals, first generation antipsychotics, long acting injections, and other meds, such as mood stabilizers, used a lot, antidepressants, and anxiolytics. Some prescribing nuggets for you. Keep in mind of dosing schedules and formulation. Don't discount your first generations, especially if cost is a concern. Don't fix what isn't broken. So if you're getting a patient who's been stable on their medication, I wouldn't go about changing it very quickly. Um, Consider risk of metabolic syndrome. However, don't consider this a finite contraindication. Quetiapine, Seroquel can be misused. Please don't use it for sleep. It's not indicated for sleep. So for patients who are stable and not schizophrenic, I would not give quetiapine for sleep. Treat the symptoms, i.e., sleep or anxiety. Automatically adding anticholinergics such as benztropine is not standard of practice. And again, meet the client where they are at. Long-acting injections, these should become part of your uh, practice, depending on where you are practicing, but these should be part of what you use. They're helpful only if the client is reliable enough to come into the clinic every 2 to 4 weeks. However, many clients aren't reliable, not many, but some are not reliable to take their medications every day. They can be very expensive. Almost all, except Invega Sustenna, which I love, by the way, require a concurrent PO dosing for 2 to 4 weeks. Um, Use caution if particularly concerned about EPS or extrapyramidal symptoms or tardive dyskinesia. Um, may not offer a significant advantage if the patient already has to take other oral meds on a daily basis. Ongoing monitoring. You want to monitor their weight, their BMI, their blood pressure, EKG, especially for meds that can uh, prolong the QT interval, such as ziprasidone or lurasidone. Lab work, at least annually, obtain routine labs, including a lipid panel, glucose screens. Patients on clozapine require weekly CBCs. An AIMS score, very important to learn how to do that. Um, that's the abnormal involuntary movement scale. You do it initially, then every 6 months. And it's for early detection of tardive dyskinesia. It's a nice scale. I use it a lot with my patients on antipsychotics because that's where they will develop tardive dyskinesia. And some other interventions, like we talked about, clozapine. Consider if second generations or first generations have failed. It is difficult to manage just due to the level of blood work they have to get done, but it is extremely effective. There is a risk of agranulocytosis, rare but severe, and risk of metabolic syndromes is very high. And of course, don't discount therapy. Just because they have schizophrenia doesn't mean they can't benefit from life skills, cognitive behavioral therapy. In fact, I would argue that schizophrenic patients should all have like an ACT team or someone that works with them to help them manage life or do things, get out of the homes, be active. And I have schizophrenic patients who work, who do quite well. Case management's important. Structured living can be important. Exercise, smoking cessation. Yes, patients with schizophrenia can quit smoking, so you can help them with that. I would also monitor for alcohol use or drug use. Many patients will abuse substances to try to treat their symptoms. So just be mindful of some of those interventions that you're screening for that frequently. Um, we talked about this before a little bit. Why do patients stop taking their meds? Well, cost. Um, and their symptoms are better or are they worse? Forgetfulness, disorganization, lack of understanding of their diagnosis or treatment expectations. We may understand it and expect that they would too. So having a clear understanding of their diagnosis and treatment expectations. They have to make some necessary life changes, like taking with food. For instance, ziprasidone Giadon or lorazepam Latuda. You have to have at least 300 calories when you take that. Can require frequent blood draws, such as clozapine or lithium. And then side effects, weight gain, galactorrhea with risperidone, paliperidone. I've recently had both a male and a female who developed galactorrhea with risperidone. So I had to stop that and change that. Sedation is a big issue for many clients. So, in summary, psychosis is not a symptom. It's not a disorder. I'm sorry, psychosis is a symptom. It's not a disorder. Schizophrenia and schizoaffective disorders are chronic, debilitating chronic mental illness. Treatment is focused on managing symptoms and improving quality of life. And again, I will say that I have many patients who have a nice quality of life. They work, they take their medications, they're doing quite well. I have some, of course, that are more serious, but it's really always nice to see when their symptoms are managed and they're doing well. Um, More is not necessarily better as far as medications, and recovery is possible. So we're going to spend a little more time here now talking about neurocognitive disorders, and this would include delirium and dementia. So for delirium, you can have disorganized cognition, impaired attention, disturbances of consciousness, sleep disturbances, hypoactive or hyperactive behavior. Causes for delirium are dehydration, urinary tract infections, especially in the elderly, right? A respiratory infection, that's like pneumonia, renal or liver disease. I've seen that before. Thyroid abnormality, medication toxicity can cause delirium. Self screening, you want to do blood work, check therapeutic drug levels, urine, chest x ray, consider tests such as an RPR VDRL for syphilis, heavy metals. Remember, don't order a test unless you know what to do about an abnormal result. Interventions. Psychotropic medications should be used cautiously, if at all. And there are recommendations for what meds to use, if at all. Some of them you don't want to use, particularly in the elderly. Minimize stimulation. Utilize family. Orient frequently. Regular fluids, toileting, antibiotics for infectious processes. Minimize use of restraints. Typically, these by this point they may be in the hospital, or they may not. But most times they're in the hospital when they're this sick. So we're going to look a little bit at dementia. Uh, we have Alzheimer's dementia. It's the most common type of dementia. It's a progressive disease beginning with mild memory loss and possibly leading to loss of the ability to carry on a conversation and respond to the environment. Um, Alzheimer's disease involves parts of the brain that control thought, memory, and language, and it can seriously affect a person's ability to carry out daily activities. Um, and accounts for 60 to 80% of cases of dementia. Vascular dementia, about 10% of dementias cases are linked to strokes or other issues with blood flow to the brain. Diabetes, high blood pressure, high cholesterol are risk factors. Symptoms vary on the area and size of the brain that's impacted, and the disease progresses in a stepwise fashion, meaning that symptoms will suddenly get worse as the individual has more strokes or mini strokes. Lewy body dementia. Here we have a picture of Robin Williams. He uh, was diagnosed or suffered from Lewy body dementia. So, in addition to the typical symptoms like memory loss, people with this form of dementia may have movement or balance problems like stiffness or trembling. They also experience changes in alertness, including daytime sleepiness, confusion, staring spells. They may have trouble sleeping, visual hallucinations, and so It's quite a debilitating disorder. And then we have Pick's disease. It's typically for younger men. It's a type of frontotemporal dementia in which the neurons in the brain gradually stop working. And as the brain cells in the affected area fail, those areas atrophy or shrink, and patients lose the ability that these areas once controlled. And then there's Parkinson's disease. It's considered a type of a neurocognitive disorder, but does not present with impairments to memory, language retrieval, or executive functioning. So the etiology of Alzheimer's, um, definitive or diagnosis is only made post-mortem. So it has those presence of neurofibrillary tangles and beta amyloid plaques. Acetylcholine transmission is disrupted, resulting in neuronal death. Can be genetic. Lifestyle factors may have an impact. As I shared earlier, long-term use of benzodiazepines have been associated with increased risk of Alzheimer's dementia. Greater than 3 months or a rare use did not change the risk, but greater than 3 months increased the risk by 32%, greater than 6 months by 84%. So some other dementias, as I shared earlier, vascular dementia often can coexist with Alzheimer's dementia, occurs from tiny infarcts in the white matter. Risk factors and clinical presentation may be similar to those with cardiovascular disease or cerebral vascular disease. Lewy body dementia is the presence of Lewy bodies found in the substantia nigra. Presentation is similar to Alzheimer's dementia, but they do have those hallucinations. They can have balance problems, movement issues as well. And Pick's disease, behavioral change is more common than memory impairments, and onset is often seen in men between the ages of 40 and 60. Screening, well, you have your MMSE, your mini mental status exam, and the MOCA, very important, generally considered more clinically well relevant. Um, you assess the stage of dementia to determine most appropriate pharmaceutical intervention, if at all. Cholinesterase inhibitors, you have your Danzapro, uh, I mean, Zanat, and Aricept, not helpful um, all the time in the late stages of dementia, really probably not at all. And consider interventions such as reducing medications when dementia has progressed to late stage. Use of antipsychotics in dementia. Olanzapine, Zyprexa, risperidone, aripiprazole show modest benefit for aggressive behaviors. Seroquel, quetiapine is not necessarily as beneficial. There are significant adverse risks such as cardiac events, sedations, falls. So be very careful, especially in the elderly, if at all using these medications. I might leave them, unless you specialize in geropsych. I might even get these patients to a geropsych if you can. Use must be weighed against relative risk. Be mindful of the use of chemical restraints for people. Again, that's not how we want to practice, so be mindful of that. Dementia with behaviors is not a diagnosis, so use correct terminology. And then there's other types of neurocognitive disorders. We have Huntington's chorea, HIV/AIDS dementia, a traumatic brain injury. If you recognize this football player in the back, he ended up developing dementia. He had some multiple traumatic brain injuries. Um, so screen your patients for a history of concussions. Creutzfeldt-Jakob disease, or mad cow disease. And then something too that you might see frequently is a Wernicke-Korsakoff syndrome associated with alcohol abuse and thiamine deficiency. So, in summary, delirium is a temporary state, and dementia can be multifaceted. Um, Managing neurocognitive disorders takes a comprehensive approach. Include other specialists as needed. I always would recommend that. And that's it. So next week, you're going to be looking at violence and personality disorders and some forensic issues. You'll have video training on violence, domestic violence, and some discussion boards, and be looking at personality disorders. And again, wish you all a great week.